Hi, everybody. I just kind of want to get a sense of who you all are. How many of you are undergraduates? Okay. And you're not an undergraduate?
Oh, I'm an employee.
You're an employee? Okay.
Thank
and
you.
so
You're very sweet.
yes, I know. So how many of you are employees then? So 2 employees, okay. And then I'm going to quickly go around just so to help me so when I talk, I can kind of address kind of who you are and what you're studying. Can you just quick tell me your majors?
Social work.
Social work, oh great.
Marine biology.
Cool.
Art education.
Okay.
Psychology.
I'm sorry?
Psychology.
Psych, okay.
Psych.
Psych.
Art.
Art.
Business.
Business. Psych.
I'm psych.
Psych. Lots of psych.
Early childhood education.
Okay.
Early childhood and special education.
Okay.
Early childhood education. Applied disability studies.
Applied.
Disability studies.
Oh, okay. Oh, that's an interesting major.
Psych.
Psych.
Business.
Business. Nursing.
Psych.
Psych. And are you from nursing as well? Or?
No, I'm the director of online programs, but
Oh.
I have a background in healthcare. I was a cardiovascular tech in the cath lab.
Oh, great.
8 years.
Okay, so we have a diverse student population, and so I'm going to be talking about immigrant health issues, but I'll try to pull in kind of how that applies to you. And then another quick question. Does Millersville have a Greek life? So there is Greek, okay, all right. All right, so I have a purposefully provocative title here today, mainly because of what we hear in the news and the provocative political discourse that is going on that I find quite troubling. But this first part of this, some people build walls and others open doors, is actually a line from a Jackson Browne song, so I have to give credit to Jackson Browne. And I was riding around thinking about a bunch of things, and that song came on, and I'm like, that's it. That's how I want to focus this talk. So now, here's my own disability. Oh, now what did I do? Okay. There, okay. So here are our walls and our doors. And thinking about as we move forward this afternoon, I mean, walls are valuable, right? We've got them here. They protect us from things in healthcare. They can serve to isolate people who are ill, which is really good. But it also can isolate people from others. So walls can be problematic. And doors within those walls can be helpful to pass through and enable people to get to other places. So when we think about the issues and the discourses going on politically, you know, I can't control what other people say. I learned that at a very young age. But you can control yourself and you can control your own actions. So thinking about your role in the walls and the doors. And at the end of this talk, I'm going to have some examples of some student projects that influenced walls and doors. So in the US, we have over 13% of foreign-born population. And so that's a pretty good number of people. It's over 42 million people in the United States that were born in another country. And most of us, if we trace back our own roots, very few of us were families originated in the United States. We came from other places. I actually am a grandchild of Irish immigrants, and I remember my grandparents and all their relatives here in the United States. So that is a big part of what informs me, and I guess that's why I care, one of the reasons I care about immigrants. I also find it disturbing when people are powerless at any area, and so I guess that's what put me in public health. We have 11.4 unauthorized immigrants. Now that may be a different term to you. Typically people say illegal immigrants or undocumented, but the new term now is unauthorized. And in reading about making the transition to this term, one of the authors said that it's not illegal ever to be a person. So I really love that, especially since today's about justice, that there's nothing illegal about being a human being. So we got to get rid of that term completely. And really, when you think about it, people have crossed the border and don't have the proper permission, so they are essentially unauthorized. And that these slides will be available. That's the link to the Migration Policy Institute that has a lot of good information. So I have those embedded. So who are immigrants and what what are the different classifications? And I'm going to read this because I want to get the terminology correct. First of all, an immigrant is someone who was born in another country and then has moved permanently to a country. So in this case, it would be the United States. So anybody who's born somewhere else and moved here is an immigrant. A refugee is someone, and this is according to United Nations refugee conventions, and this is why I want to read this, is someone who is owing to a well-founded fear of being persecuted for reasons of race, religion, nationality, membership of a particular social group, or political opinion, is outside the country of his nationality and is unable to, or owning of such fear, unwilling to avail himself to the protection of that country. So there are things that are going on in that country that makes the person feel unsafe, and they're unwilling to be protected by whatever is going on in that country. So I think many of you were in the earlier presentation where they were talking about detaining immigrant families and the people coming in from Central America. So, many of those unaccompanied minors were coming in because they were unsafe. So they essentially, the minute they cross the border, are considered a refugee. Okay, and that's one of the keys of being a refugee is you've got to cross into another border. If you stay in your own country, you're actually a displaced person. So, and we're talking about crossing borders here. So that's what a refugee is. We also have asylum seekers, and they are people that have gotten into the United States or whatever country you're talking about, but in this case, it would be the United States, and then have the same issues as a refugee. But they have not. A refugee has to pass through checkpoints to become a refugee into this country, and we're going to go over that. But an asylum seeker comes into this country, so they may come in unauthorized, but then say, well, oh, by the way, I came here because I'm unsafe, or what's happening now is there's a lot of domestic violence cases that are being coming in and identifying themselves as asylum seekers. So that's another group. And then, as I said, we have the people that have come in who are unauthorized and just come in, sneak across the border. And I don't mean that as a judgmental thing, but are looking for a better opportunity for themselves. Now, in doing this work, I have learned that people don't come to another country. It's not that America's the great white hope. It's that things are not good in their own country. People don't leave their home if things are good. So we need to keep that in mind, especially when we're thinking about the bigger picture. So this is kind of a nursing and healthcare perspective. Those of you in social work may use this as well. I don't know any other psych may use it, but it's called ecological systems model. It's really, and we use it a lot in public health. But essentially what it is this a pointer thing? Let's see if it is. No, okay, but I can do this here. So essentially, the center part is the individual person, right? And that's usually who we come in contact with. Like we may meet somebody who's an immigrant or a refugee. The outside part are all those social organizations that support that person. So if we're talking about an immigrant or refugee, it may be social service organizations, it may be their place of worship, their mosque, temple, synagogue, church, or it could be the school. So those of you in education may have the experience of working with immigrant children. The other layer, the next layer out is our policies. And then the bigger macro system are our culture and our beliefs. They're actually the tougher things to change. But all of those things influence that individual. Conversely, that individual and those of us that are involved in community agencies can push back and influence policy. And that's another thing we need to keep in mind. What is our role in policy? So, when we're talking about immigrants or refugees, and as I said, people leave their own country because things aren't working out well for them. So we refer to it as push-pull, but for this we're going to talk about walls and doors. And so there are a variety of reasons why people may leave their country. Economics is one of the big ones, and that's why my grandparents came to the United States, as they couldn't find work, so they left Ireland and came to the United States to find work. We also are seeing people that are unsafe in their countries for various reasons, whether it be violence or a political structure that is not working out really well, and people, again, may be threatened. And then we're also seeing war and conflict areas. And now we're also seeing people that have problems maintaining or getting subsistence sort of things like food and water. So issues of climate change, issues of climate refugees. We're seeing all kinds of things where people are moving from their home environment to another country to try to meet those needs. So here is a picture of Syrian refugees in Turkey. And what do you see in this picture?
Children, families.
Children and families. What else do you see?
It looks like they pretty much have all of their important belongings.
Yeah, they have everything that they could carry with them. That's it. Okay? These are people, these are families who have left nice homes like you and I have, grabbed what they could to get the heck out, and sometimes they don't have much time, to cross border, and once they do, they become a refugee. And then they become under the auspices of the UN High Commission for Refugees. Okay, so then that's when they kick in and start to help them. Okay, so we need to keep in mind, again, hearing the rhetoric, that's another reason why it's probably good I can't turn on the television, because I think I would need to be medicated, that we can say that people are looking for opportunities and all that kind of nonsense, but this is how people come. And I actually, we're going to get into some of the work that I've done. I've met people on day 3 of just arriving in the United States, and they don't have anything. They have left everything. And again, many of them are educated people and left their homes and never, ever, ever asked for this. Okay. All right, so when we think about what services and who is coming over, again, as far as who comes in as authorized people, we have the immigrants and refugee status. So immigrants, we allow in about a little over, well, actually almost 700,000 a year people. And then there's 3 classifications of how people get in. They're either family sponsored, so they have a relative that's in this country, employer-based. So we do, like many countries, will seek immigrants to come in to fill skilled needs. If we need somebody with certain expertise, we'll be bringing them in. And then diversity-based. We do try to get a diverse population, which is all good, and it helps certainly the U.S. society. And then as far as refugees, as I said, they're under the auspices of either the UN High Commission for Refugees is how they kind of get approved and processed, or the U.S. Refugee Support Center is another group that will approve and process them. And the processing takes about 24 months. Now, that's a long time, except usually they're in the camps much longer, and I have a photograph of the camps in a little bit, much longer before they even get here. So I have met people that have been in camps for 24 years. I met a girl a couple weeks ago, 18-year-old, lovely woman from Pakistan. I met her on day 3. Thank goodness I'm trying to think of what country they went to. I cannot remember, that's escaping me, but she and her family came to the United States. She had been in a refugee camp for 16 years. That's all that young woman knew. And she was so excited to be able to get here and finally go to school, because you can go until you're 21. So she was like, just when do I start? She wanted to get into school so she could go to university. So anyway, it's a long time that people are in the camps. So that's a picture of some of the camps. No trees. So this is areas, it tends to be kind of desert, remote areas. This is not a garden spot, okay? And people are given enough food to meet their energy needs, but again, it's not the greatest food, and that's really all we're doing, is trying to meet their energy needs, especially with the winter coming. They need to increase their caloric intake, and so that they can make it through to the next year. So it is kind of an awful existence. In some camps that are there for a long time, schools are established, but look at the environment. So it's not like we're bringing in a lot of teachers. I mean, there are teachers there, but it's bare bones of what we can expect from these students. So thinking about the impact on a population of not having an education for many years, that's another problem, and we need to deal with when they come to the United States or anywhere else. Oh, yeah.
These camps, okay, you said processing takes 12 to 24 months.
Yes.
Where is the camp located? Because they're staying at the camp before their process, or like while
Yeah,
they're
so this is, the camps are set up, so during the crisis, right? So, saw all the Syrians coming over the border and this, I guess, 6 months or so ago. So then the camps get set up, and then people stay there, and then they start sending people out and figuring out. So each country will say, okay, we can take so many, and we can take so many. And then, and we actually, the United States does not, don't have those data, and I wish I would have it. But the United States does not take nearly as many as other countries do, mainly because of proximity. I mean, the other countries are closer, so they just can stay there. European countries are closer. But they will stay there until then kind of the door opens up. We only take about 70,000 a year, refugees. And so actually President Obama just announced a couple weeks ago that next year it's going to be 10,000. Excuse me, not 10,000, 110,000. That's more zeros, that's better. So that's going to influence, what services we can provide and then people are going to be more dispersed too. So another thing is that historically, immigrants and refugees tended to go to urban settings, but that's not the case anymore. So we're seeing immigrants and refugees out in rural places as well. I don't know, are there?
There were some Syrian refugees coming to Lake.
Yeah, yeah. So we're seeing more.
So once they're in the how do they prioritize them within the camp?
Yeah,
Is
that's
it just
what I
sort
was
of a
gonna
first come, first serve, or?
Yeah, and they do it by need, they do it by connection. So if they have family in that country, they'll try to get them there. They do their best. The thing is that people, once you're 21, you don't go with your family. So, and I'll show you a picture of a lady in a little bit, and she just breaks my heart. Her adult children are dispersed throughout the world. And she's like 84. She probably will never see them again. So again, this is a lady that was not how she planned her retirement. And that's, things that, the humanity of all of this is really a big problem and a big issue.
So their time in the camp, like, is it like they're waiting in line?
They're waiting,
and,
yeah,
like, just
yeah.
trying to get their name on the right list?
You're right,
Horrible
yeah.
business.
And then, there's basically like clinics as far as management health care. It's minimal,
Right.
whatever they, certainly they're looking after infectious disease because they don't need an outbreak of cholera or TB or anything like that. But the other stuff is just like, well, hopefully you'll make it till tomorrow. So, and the truth also is, the world is in more and more conflict, so we've got people displaced more than we have in the longest time, and so, that's not financially sustainable. So we need, so there's less and less resources that are available.
What do they do, when they're coming in and they're pregnant or delivering? Like, how do they meet the needs of infants and stuff like that?
How do they meet the needs?
Yeah.
As best they can.
Okay.
So, and they'll get to a point where they can't take anymore, and then that's it. Now, interestingly, Kenya has the largest refugee population in the world, which is, again, a poor country. So we're asking these low-income countries to share the brunt of this, and that's one of the messages I want to get through is, what can we do about that? And we'll get to that in a little bit. So, what does that mean for health insurance? So an immigrant, as I said, they have to be approved to come in, they have to meet certain classifications, and so somebody who comes in as an immigrant is certainly able to purchase health insurance so they can purchase, whatever policy they are able to do. Or if they come in with an employer, they are able to get under the employer's benefit, which is probably their best deal. If they are low income and they come in as an immigrant, they can qualify for some Medicaid, which is the insurance for people who are low income, and also CHISP, which is the Child Health Insurance Plan, okay? Except they have to have been here 5 years before. So what you do is you take your vitamins and you hope for the best. I mean, really, that's what's happening if they aren't able to get insurance. Now, with the Affordable Care Act, there are some more options, and it is making it better. And some of the organizations that I work with go out with vans and help register people to get them some health care, because I don't know about you, but I'm sure you've been to see a doctor within 5 years. I mean, something's going to happen. Strep throat, something. You're going to need health care. For refugees and then asylees, because once they get approved as an asylee, they then get the refugee benefit. They're then counted as a refugee. So they go through the Office of Refugee Resettlement here in the United States, and they do get some benefits when they first come in. It's not a lot, but they do. They get 9 months of health insurance. Okay? Now let's just stop and think about this. You saw the picture where people are coming from. So you also then think about, well, they may not have had education. They more than likely are not fluent in English. And chances are, if they had education, I've met physicians, lawyers, engineers, those records are not available. So nobody is contacting the bursar's office the registrar's office to get their transcript at whatever university they went to. That place isn't there anymore. The registrar is gone. They're probably in the camp with them. So they get care, they get health insurance for 8 months, and then we're on them. Did you get a job? Did you get a job? Did you get a job? And so we may find engineers and physicians working in housekeeping in a hotel because they don't have the English skills yet. And that is a pretty awful experience, if you can imagine.
And even if the registrar was there, 8 months is not long enough to get
Right.
everything through that
Right.
system.
Right.
Of getting them approved as a physician or a nurse
Yeah,
here.
yeah,
Just
and
because
right, and the physicians that I know, I don't know of any nurses, but I do know of physicians. What they have done is they have worked their way through medical research and gotten in that way, and so they're not actually practicing clinically, but they're working in their field, and that's worked out okay. But it takes a long time. So they have 8 months to do that, and they have 8 months of rent. Now this is government subsidized rent. Okay? So they're not living in a luxurious condo in Boca. They are living in very low income communities with sometimes unscrupulous landlords. So then we've got all the issues of violence in the community. We've got probably lead-based paint exposure. Roaches are very common. So all of those things that people are dealing with in a place where, again, they may not speak the language, so they don't even understand how to prevent those sort of things, and they don't know how to access those things. So that's kind of the profile of when people first arrive. These are the folks that come in, immigrants that come in lawfully, and so we have, these are the 5 major countries that they come in, and the population, that was from 2014. So that's where we see most of the people from. And then these are the states, the 5 leading states or receiving states of our immigrants, and Pennsylvania is about 13th. It may change a little bit with the refugee quota going up, but we're not as high. But California, New York, and Florida, and Texas have always been big receiving states, and they continue to be so.
It's interesting that Texas is, I know they're on the border for Mexico, but they're not exactly the most hospitable
Right.
environment for
Right.
for
Right.
immigrants. that's interesting.
Well, yeah, I mean, and we hear that on the news, except for I do talk to some public health people down there who really do reach out. So there are people that are trying to help. But yeah, you hear, and you
My
know.
partner's from Texas, so I'm allowed to pick up.
Okay, and in Texas, in their defense, I mean, if they're getting pelted all the time with, you know, it can make you cranky. Because, so, you know, we've got to understand both sides too. So I do kind of get that, but we need to think about why that's happening, and hopefully we'll get to that too. And then these are the refugees that are coming in. And as I said, it's close to 70,000, but we're going to go to 110,000 next year. So that's a big jump, and so we need to make sure that the agencies are prepared to deal with that, and that we all are. What is our role, and how can we deal with that? And then these are the regions of the world that people are coming from. This is our unauthorized immigrant population, and the earlier speaker said pretty much the same thing, that, you know, we hear in the news of all these people crossing the border. It has leveled out. It is not this horrible thing that you know, people are talking about. I mean, there are 11 million people crossing the border annually, so that is a lot of folks. But it's not taking off, and it's not out of control. We have leveled it out, and if we think about the push-pull of why people are leaving, maybe we can address that, and people then won't feel the need to leave. And that's really, if you want to make a difference, that's where you're going to make the difference. So the golden ticket I have there is, to be facetious, and forgive me, because when a refugee comes to this country, they have earned an awful badge to get here. They really have. They have been exposed to violence, maybe inter-partner violence, or gang rape, or any sexual assault. I have done focus group interviews with Iraqi refugee women, and they described the torture that their family members were exposed to. So if they were not tortured, they have observed torture, if you can only imagine somebody doing that to your family member. And so there's a lot of mental health issues that people come with, and that is actually not being addressed really well, and that's something we need to look at. And then they may have been victims of trafficking, and also severe persecution of, you know, for being members of a certain group. As I said, mental health problems are really big. We do this health screening, and I'm going to talk about it in a little bit, and we screen for stress. Again, this is early arriving people. The stress is off the charts of the stress that they're feeling. But a lot of post-traumatic stress disorder, anxiety disorder, depression. They may have neurocognitive problems, and some of that may be related to head injuries from torture. I did a health assessment of the Arab immigrant community in Philadelphia, and initially I was seeing that people had a lot of neuromuscular problems, like physical disabilities because they had problems walking, and I was thinking, what is going on? What is, you know, do they have bone injuries? What do they have, like a genetic thing that leads to poor bone structure, or what is happening? And I started asking more questions, and I think I asked that, do many people have, and they just said, no, it's torture. It is from, and so it is very real that people are exposed to. And then another thing, and this kind of gets to the issue of camps, chronic disease is not being managed. Now, cardiovascular disease, which includes high blood pressure, people that have had heart attacks or strokes, that is a common health problem throughout the world. And so is diabetes. And I bet you all know somebody like your grandparents or somebody that has these conditions. But they are getting medication, they're taking their insulin, doing whatever they need to do, getting the right diet. But when people are in the camps for a long time, that's not happening. So we're getting people that, I mean, we saw a man last week who was 54 with a blood sugar in the 400 range, which is really high. That's really high for you. I'm sorry, forgot I'm not talking to nurses. But his blood sugar was very, very high, and his blood pressure was also very high. And I was saying to him, we need to get you to the clinic, we need to get this treated. And he said, no, I need to go get my Social Security card so I can get food for my family. And I said, okay, get that Social Security card and then go to the clinic. Like, because he's right, he needed to take care of that. So there are the choices people are making. So this is Habibi, and that means dear one in Arabic. And I call her that because I can never remember her name, and she calls me that. And this is the lady that I was saying. She is 84 years old, an Iraqi refugee, and she came here just with her daughter, and she has 5 other children. And one is in Egypt, one is in Australia, one is in Germany, and she's not in the greatest of health. And so I really doubt that she will ever see them again. And when she talks about them, she cries. And again, I mean, that's the human face of what we're doing when we have conflict. They could Skype. Well, okay, so, well, but for her to travel, let me say she went to Lebanon. She did like a year or so ago, she went to Lebanon to visit one child. So she was able to do that. But this is where they've been placed as refugees, and they can't just then apply, especially now that they're adults, they can't apply to come to another country as, you know, to visit. So that's the way it is right now. But as I said, she got to go visit for a while, and then she came back. But her family will never be together again as a family. And if you know anything about the Arab culture, family is like cutting off somebody's limb to remove them from their family. So it's just really heartbreaking.
It's really just that when you're in the camp, when they say, "Oh, we have a placement for you," you go where they place you.
Yes. You don't get to
say,
negotiate.
I'd really like to go to the United States.
Yeah, right.
You just
Exactly.
go
Or the
wherever
south of
placement-
France is sounding nice. No, you don't get to do that.
So you go where they put you.
Yes.
They would try to keep families together.
They do. Well, they do. They keep, but you know, at a certain point, I mean, in the Arab community, it's really tribal. So a family in their eyes is like 40 people. You know what I mean? So you can't, you know, all the cousins, and so you can't do that. So this is the rule, that they'll take, you know, you and your minor children, and then older children, they may go somewhere else.
But she did get to go with her one daughter. you
She
said.
got to go with one daughter, so her daughter takes care of her, and that's.
That's tough.
But it's just,
Yeah.
I just think that picture should go to Congress. Like, that's just not right.
These people's lives are just like torn apart, like over
Yeah.
and over and over
Yeah,
again.
yeah. And I mean, all she was doing was, you know, being an old lady at home. She never asked for this. So, and raising her children as a good mom, and yeah. So, other walls as far as health access for our non-native born Americans, so our immigrants and refugees, is, I don't know about you, but I have a hard time navigating our health system. And there's times that I just don't even bother going, and I'm a nurse and know better, because it's a pain in the neck, right? It's just so confusing to, you know, I need to go get this form and this approval, and then I have a certain amount of time and I can go. And so can you imagine having to do that when you don't understand the transportation system, you don't really understand the language, and you may think that people are being rude to you, okay? So that's another problem, is health access.
I was just gonna say too, if you're unauthorized, you're not gonna go to the hospital.
Well, yeah,
I mean,
exactly.
I work as a teacher, and I used to work as a teacher, I'm an RN, and when I was teaching during the swine flu epidemic. I had students come in that were literally deathly ill. We had to send two to the hospital because they were unauthorized, and they did not want to go to the hospital, but they also didn't want to stay home, because if they're home too many days sick, then they're truant, and we're still coming to your door, and they needed like serious medical attention. And then the school district was concerned the parents are being negligent when they were just trying to stay under the radar.
Right,
And
right.
it's just horrible. And even in the healthcare system, like when they do come in, they're like seriously ill. Like they don't come in when they have a minor ailment. Like they're in the process of having a heart attack, when they might be having chest pain for 2 days. And that's the problem too, because when they come in, now they're having major procedures where if they just come in earlier.
Exactly. So they get into the system later, absolutely. And they also, I mean, we were saying about the jobs that people have. They may be like non-skilled jobs, so it's hourly work. And so if you don't show up, if you're sick, you don't get paid. So there's no sick time. So, I mean, it's all of these things. I am not a nurse practitioner, but when I'm out in the communities, you wouldn't believe people are like, well, can I do this? And they are asking me to manage their health conditions because they don't want to go in. And as you said, they avoid seeking health care. Number one, and those of us who work in any kind of social service field, we really need to work on, you know, how we are working with other people so that we are not projecting discrimination or some opinions that we may have. Working with someone whose language is not English, or working with someone who has a cultural different worldview takes extra time. And it can be frustrating, but it also can be very rewarding. So we need to be aware of that. And then also the fear of alerting the authorities. Now, after 9/11, there was this panic and craziness. And we were, in the healthcare field, supposed to report any unauthorized person. But the public health sector pushed back on that, because we want everybody that needs help to come in for a variety of reasons. As you said, if we come in late, they're only going to get sicker, so let's take care of them right away. The other reason, for a public health perspective, is we don't want anybody roaming around out there that may have tuberculosis, any kind of disease that could be infectious or communicable. So that's how we push back and successfully won that we don't. In healthcare, we don't report on. We don't ask that, and we don't report it, except for in some clinics they may not treat people. They'll send them somewhere else. So, like the federally qualified health clinics, they can't treat them, but they don't report them. They send them somewhere else. So it gets kind of dicey.
I can say two of our graduate nursing students and I did a survey just in Reading, Pennsylvania, you know, just down the road, of undocumented, unauthorized immigrants who are migrant workers. So they, you know, go out and they roam the eastern seaboard, essentially, you know, doing that. And they told us clearly the three biggest factors that they don't go is because they're undocumented. It's time, that clinics aren't open during the day, it's money, and it's language.
Yep.
And we really wanted to set up a clinic for them, and the barriers to doing that are insurmountable. That's what we found.
Right. Yeah, it is challenging. It is. But there are, I know there's...
There are some.
Yeah, there are some.
For our little
Yeah, and it's a shame. There are some, because I'm in Chester County, which is the next county over, and we have the migrant workers, Kennett Square, the mushroom capital of the world. And so there are some clinics there for the workers.
They're federally qualified.
There's some that aren't. There's some that and really target just the workers for that reason. So anyway, so there are things to think about and the barriers that are very real. But there are additional I was thinking it positive. This is still barriers. I talked a lot about language, and I'm going to talk about kind of how we overcome that in a little bit. Certainly cultural practices. So if you're in an area, with social work and teaching, and even in business, if you have a large group of people from one area, one population. I talk a lot about Arabs because I work with a lot of Arabs, but any Latino group, take the time to learn what their cultural practices are. It just makes life easier for everybody, and it is welcoming. I mean, we are a country of immigrants, and we, just because we were here a little bit longer doesn't make us any better than anybody else. The other barrier can be, as far as healthcare access, is location. As I said, a lot of times people are in low-income housing because that's what they can afford initially. So that's usually not where primary care is. That's not where the clinics are. That's not where the doctor's offices are. That's not usually where accessible transportation is. So those kind of barriers, so those environmental barriers can be an issue as well. The other thing I said, people tend to be low income. What we've learned also in studying immigrants is that first immigrating generation tends to do worse than they did in their home country, but the subsequent generations do much better. So, you know, this is a group of people that we do really want to support because their kids are going to go on and do, you know, be great citizens for us, our country, and that's what we want.
Parents come over as refugees to them. So you're not born yet, and then you're born in this country. Are you declared a refugee?
No, you're a citizen. If you're born in the United States, you become a citizen. So this is my language talk. So anyway, I did go to have a study this summer at my local hospital, and this was at the registration desk, this sign. And I'll tell you, you ever want to get through registration quickly, start taking pictures of things. I was making the guy really nervous, and he got me through really quick. It was wonderful. I may do that all the time. But anyway, there was this sign there. I did say to him, I'm not taking you, I'm just very interested in this sign. So this sign there, and it says, we ask because we care. And so they ask about race, they ask about ethnicity, and they ask about your language that you prefer to use. And so that is really a positive, that we're starting to do those things in healthcare. There is a law, it is the Human Rights Act, I believe. I know it was enacted in 1964, that we can't have barriers to healthcare. We have to improve access. And one of the things says that for non-native speakers, so people who, for English is not a native language, who have trouble reading, writing, or speaking English, we need to accommodate. So it is a law that healthcare providers accommodate if they get federal funding. So that's pretty much every healthcare agency, because the minute they accept Medicare, they got federal funding, okay? And our system is staying afloat by Medicare. And arguably, I don't know if we could look at the Affordable Care Act, but you could twist that to say, well, this is an Affordable Care Act insurance, and so that's federal funding as well. So what we do is the ideal thing is that we have a medical interpreter, somebody who understands healthcare and the language that can interpret. So that's the best if we have like a human being to do that. But that's can be challenging if you're dealing with people from all over the world. And so what we also have is called a language line. And so we can phone in to an interpreter, and then we either put it on speakerphone, and we have two phones that we can hear. And then the person is talking, and then the healthcare provider is talking. And so you're making sure that everything's clear on what's going back and forth. And that's the way we can solve that language issue. So we really are trying, and things are moving along that way. And we are trying to get better about understanding culture. There's accreditation requirements and requirements for kind of like awards like Magnet and things that if the hospital system or the health system is acknowledging cultural things, they get kind of extra points. So that's all ways to entice and make it more accessible to our immigrant population. The other plus is that those who come to the United States do tend to be, with the exception of the refugees, but the immigrants tend to be younger and healthier, and truly the undocumented really are. I mean, think about how they got into the country. So this is a really healthy group of people. So that's, they're healthier than we are, and they're on arrival, they're healthier than we are. Now, also what we have found in research is as they stay longer, that goes away because they adapt some of our American practices. So, again, we have a lot to learn from our immigrant population. The groups that aren't doing as well are the Middle Eastern and Russian populations, but think about what's happening there. The Middle East is having a lot of turmoil, and so they're coming from places of where they may not be getting all the services, and Russia economically is struggling, so we have some food shortages and problems. So you've got to look at it. People don't live in isolation. It's all those things going on around them. With the refugee populations, this is what they come with, and for us to understand what they're coming into this country with. So it is important from the healthcare perspective, but also thinking as you're helping people, perhaps navigating through the system, to understand the system that they've come from. And it is very interesting to kind of get into that and understand all that. Understand what resources people are used to having. I did a breast health program that I'm going to go over with you in a little bit, but with Middle Eastern women. And in some countries, there is no mammogram. So for us to even say that, they're like, what are you talking about? So we needed to understand all that before we could move forward to making sure women get adequate preventative care there. And then, as I said earlier, diseases may not have been managed or may have been mismanaged. People may not have had the proper nutrition. So those kind of things. Also, navigating getting a prescription filled can be a challenge, because in some places you go to the doctor and it may be right at the hospital, then you go to the pharmacy there and they fill the prescription. Or you don't even need a prescription and you just go to a pharmacy and you tell them what your problem is and they give you medication for that. So you need to understand what people are coming from, for us to be able to explain to them how we do it here. The other thing is over-the-counter medications are kind of a foreign concept to people. Again, and that tends to be in countries where you go to the pharmacist and tell them what you want and they give you whatever you need. So, explaining, well, we've got this class of drugs that you can just go and get, and then we've got this other you need a prescription for, and it is confusing to us as well. Also, we need to think about, in thinking what people come with, the genetic factors of the population. People, what are the risks of that group? With the Arab immigrants, sickle cell disease is a big issue, and also some anemias are a problem. So we kind of gear in on that. Environmental exposures can be an issue. With the Iraqis, there was some chemical exposures from war, so we need to think about those issues. And I mentioned about mental health problems can be a problem. So I'm going to kind of go through examples of what I've done at Villanova, primarily with nursing students. And the reason I asked if there's a Greek life is because these are great service projects too. The focus is on health, but there's no reason why you couldn't do some of these projects, with a school organization or a faith-based organization. They were very successful, and some of them were fun. So the way I got involved initially is when I was working on my doctorate. My study was, at Villanova we have nursing students from Oman, and it's a small country on the Middle East next to Saudi Arabia and Yemen. And that was my research. I looked at what their experience was. So I really had to learn a lot about Arab and Arab Muslim women. And so since I learned all that, somebody introduced me to the Arab American Development Corporation in Philadelphia. And so I started taking my Omani nursing students there because I thought that was a nice match for them. They get to work with people who speak the language they're accustomed to. And this is actually a flu clinic. That's Mayor Nutter, and he was the mayor of Philadelphia. So this is actually an organization that gets a lot of attention in the city. And both Mayor Nutter and now Mayor Kenny have been very supportive of Arab American Development Corporation. But then I moved on to thinking, I should bring U.S. students to this organization, because one of the things that is going to kind of change hearts and minds and really make us better citizens and speak up to some of the nonsense that we hear out of our political figures is knowledge of other people. And so that was kind of my hidden thing, is I wanted to get U.S. nursing students exposed to working with Arab people. And in most service jobs, we need to understand what it is to work with people from other cultures. So it really was a win-win. And so this is a nursing student who is taking a blood pressure of an Iraqi refugee. And this woman standing is the caseworker, and she's doing the interpretation. So from an educator's point of view, this was really another great opportunity for nursing students to get to work with an interpreter, because working with an interpreter is a challenge, and it's a skill you have to learn. It's not like when I explain to students how to do it, they're like, oh yeah, I got this. And they go in and they're like, oh my gosh, that was really hard. And I'm like, yeah, that's why we go over how to do it. So it is, and it is actually exhausting for the interpreter. So that's something you need to keep in mind, is making sure they get a break. And this student she's actually a really good student, but I was a little concerned about putting her in the environment. Shows up in her BMW to go to clinical, and I'm like, oh God, how's this gonna go? At graduation, her parents came up to me and said, thank you so much that's all she talked about, and thank you so much that she had this experience, because I was also afraid the parents weren't gonna be so excited about it either, but it was a good thing for everybody. So they also, I think that might be the same student in the red. But anyway, they also go in, this particular organization has an Islamic day school. So, it's the same as like a Catholic parish school or a Jewish day school. And so these are high school students. And they went in and did some health teaching with high school students. And it's, again, really good. They got to learn about cultural practices. This one slipped by me, so here, your professors aren't perfect. I always review what goes out before they go out and do a teaching, and I don't know how this one got by me, but they were talking about stress and talking about, issues when you're an adolescent and when you're dating, blah, 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 and the students were like, we don't date. So, and that's true. In the Muslims, they don't date the way we know dating. So I was like, ooh, sorry guys. So anyway, but again, it's a good opportunity to learn about cultures, and so then you would know, you don't talk about that. And they had to learn about what they ate and all that kind of stuff. So, and that also was a really positive thing for both the teen group of students and our students in understanding one another, which is really important. So we moved on a little bit. So we did those basic teachings, and then we started thinking, we've been partnering for a while. Let's kick this up a notch. And so I was on vacation a couple years ago, and my cell phone rings, and there was somebody from the center, and so I took the call, and it was this. She said this grant just came out for Susan G. Komen, which is a breast cancer organization, looking at educating women about breast health. And I'm like, yes, we need to do this. So we did this grant. And this is me talking to the ladies, explaining to them what we have in mind and getting their input of would they be interested. Because that is another thing that's really important, is that we listen to what other people are telling us and what their needs are. And I'll give you some examples of disasters when I didn't listen in a little bit. So what we did with this project, and again, this is health center, but there's a bunch of things you could do. I mean, even business could do, taxes and any of those things. We always believed in the Arab community that we needed Arab immigrant women speaking to Arab immigrant women. And me coming in, they would listen, but it would not be as effective. So what we did is we trained, they're called community health workers, and they are people within the community to do the educational project. And so this is the lady in the green hijab is Shireen, and she was one of the people that was highly recommended, and we trained her. Shireen was, I'll show you a picture in a minute of Shireen, but she was like, I can't do this. There's no way I can do this. And I'm like, no, you can. I'm gonna teach you. We're gonna work through this. And she really did not have much faith in herself. But we set up a computer-based program where they educated small groups of women. So these were women that she knew, so it worked out well. Now, we needed to show that we had positive outcomes, or we needed, to our funder, we needed to show that. So we, being a teacher, I'm like, well, we'll pre-test and post-test them with paper and pencil. So a couple weeks went by of that, and another one of the community health workers called me up, and she said, this isn't working. And I go, oh, why not? She goes, they're cheating. and I said, well, let's they're not cheating. Let's rethink that. But what was happening was they were all sharing the answers. So we would call that cheating, I guess, if it was a real exam. But they were all sharing the answers. And there's two reasons they were doing that. One is, this is somebody in their own community. So the post-test, they had to show that they had the right answers. They didn't want somebody in their own community to look bad. So that was number one. Number two is, culturally, they're very collectivistic. They do things as a group. They learn as a group. They learn much better when they can discuss things together. And so that's what they were doing, is they were discussing the answers. They weren't really cheating. And so what we did is, do you guys have in your classes those clickers where you can answer things? So that's what we did. We switched it out, and we were like, okay, so we went back and got a little extra money, and also then I negotiated with the clicker people and got like a bargain basement clicker price. But we got clickers, and so because it was computer-based, we could, they could click the answer, we could show them the answer right then and there, and then they could discuss it. So, and the reason I'm telling you that is you need to adapt to the culture, and that's, you know, and there's plenty of like innovative and fun ways you can adapt to the culture. So we got the data we needed, and they got to discuss it, and the beauty of clickers from an educational point of view is you can address that issue right then and there. So if people aren't getting it, you can address why they aren't getting it. And so that worked out really well. So there's Shireen there. Look how excited she is. So after we were done, that was a 2-year project. After we were done with that, Shireen wanted to do more. The one that couldn't do it, you know, this is too much. I don't know anything. She's like, oh, what else are we going to do? And so we asked her, what do you think the needs are? And she identified weight and like overweight and obesity, and it is a problem in that community. So that is, she's not asleep, the nursing student Vanessa. She's actually looking down at the computer, but Vanessa worked with Shireen to develop a health education program about overweight and obesity, and Shireen delivered it to her community, to the women in her mosque. So again, these are projects that people could do. You know, if you're getting refugees, you could do here. You know, and it does not need to be health-based. It could be anything. So from there we also now work with the Nationality Service Center. This is an organization that helps resettle newly arriving immigrants and refugees. And so I'm sure, I bet there's a resettlement agency in Lancaster, so that you may want to look into who that is. Catholic Social Services is really involved. Lutheran Children and Family used to be involved, but I'm not sure what's going on with them.
The Mennonite.
Oh,
thing is big,
Mennonite,
yeah.
yeah. So that would be a good, that would be a good, because the Mennonites are always in on that stuff. So anyway, so this is.
The local one is CWS, it's Church World Service, and then Lutheran Refugee Services.
Okay. Okay, so these are organizations. So if anybody's in Greek Life or a service organization, these are great organizations where you can make that contact. And I really recommend you do it. It's a great experience. Some of these people are my friends now. I'm actually one of the women. Oh, the woman that I was saying was the interpreter. She contacted me recently. I'm going to her house for lunch in a couple weeks because I haven't seen her daughter in a while. So, you know, it's a very positive experience. So what we did, we've moved on then to the Nationality Service Center. We still work now with Arab American, and now we also do Nationality Service Center. We've done some nutritional education, and this is another thing, any communication majors, but you guys can just do this with your cell phones. I love film. I love videos to teach people because it's quick. So we had, because we also have students from Oman or the Middle East, and I forgot to hook into the internet, so I'm not going to bother, but you'll have these slides. The students created a film for how to go to the grocery store and how to like maneuver through the grocery store, and just because they've got pretty packaging does not mean it's good, and you know, in the United States we let a lot of sugar, stay away from that. So that's done in Arabic with English subtitles, and so that was done with both US and Omani students doing that together. So there's, again, you know, and most of us can talk about nutrition, so you don't need nursing for that. Students also did understanding over-the-counter medications, and they developed a program, and that ended up getting published in a Pennsylvania State Nurses Association journal, so students have a publication under their belt of the tools that they developed to help people understand labels and those sort of things, and what are the issues that, for immigrant people related to accessing medications. We have found that, and mostly Nationality Service Center has found, and I just happen to be a partner with them, but they found that a lot of refugee women, young women who are married, when they come here get pregnant. And what do you think why do you think that is?
Does it have somewhere to live, like privacy?
Yes, yes, right. So it is not for the anchor baby, right? They're already in the country. They're approved to be in, because you hear that rhetoric too, right? No, they have anchor babies. It's because finally they have a safe place to live. Finally they're getting nutrition, and all of those things, and the stress is reduced. All of those things affect a woman's reproduction. So if you're living under a lot of stress, if you're not properly nourished, if you're not in safe places, that affects your ability to conceive. And so that was what was happening. Suddenly there was this baby boom and they didn't know what to do. And so one of the projects that students worked with was looking at nutritional needs for pregnant women. Now remember, I said people come to this country with just their immediate family. So if it's a refugee and she's married, it may just be with her husband. Her mother and other important women in her life that would be able to answer those questions aren't around anymore. They're miles away. They may not be able to contact frequently, or they may have been killed. So this pregnancy program was actually very important to those women, because we started thinking about then how can we connect them with other women in the community to help answer some of those questions that that you have when you're going through such a life change. And so that's one of the things that came up. ESL education, or ELL, English Language Learner Education, most of these centers have these programs and for immigrants and refugees, and so we coupled on to do health education. So when they're learning English, why don't they learn the word prescription and headache and body aches and all that kind of stuff. And that actually turned out to be quite fun for the English language teacher and the students. Example of this, and this is, they did this with food too. So at the Nationality Service Center, they did the English education while they're cooking. So how do you read a recipe? And again, that's something that you could partner with your organizations to kind of get out there and help support people. Be a door, not a wall, is one thing I want you to think about. And I think this is the last one, but we've done, oh no, we have. So they also have done a community gardens, and that's very popular. I know I drove through all the farms to get here, so that's probably not a big deal to you, but we're a little more urban, so we have community gardens. But the community gardens they did was for certain populations. So the one with the students on your left is for Asian senior citizens, immigrant senior citizens, and you can see up here that these are raised flower beds. They're about up to here, so the older person doesn't need to bend down. This was funded through the National Service Center, through the EPA actually funded this. And so they raised food that was indigenous from the country that people came from. So they went and found out, and that would grow in Philadelphia. And I don't know if you know Philadelphia at all, but this is right on Broad Street, in North Broad Street. So that is a really busy street. It was a church property. They talked to the church. And so you could drive by and see how the garden was doing. And I have to tell you, those senior citizens did amazing. I mean, heads of cabbage. It was unbelievable. So I was trying to learn their gardening skills from them. So that's another good exchange. Those students, that was their clinical experience. Wasn't that awesome? I know, they're out in shorts, out in the woods, playing in the dirt. But that's what they did for their clinical experience, because they did health-related things with it, body mechanics and stuff. We do blood pressures and blood sugar, where you prick their finger to get blood sugar. We also do weight and height to get the BMI to see how they are as far as obesity and being overweight. And then we screen, do you have a healthcare provider? If you don't, let's connect you with one. And do you have health insurance? And if you don't, we connect them. I actually, I'm not a big fan of blood pressure clinics and that kind of stuff. I think it's a draw to get people in. Really the big thing that we want to do is connect them with providers, and so that's what we're doing. A couple, and this is, we just started this project this semester, but a couple of weeks ago, a student, a young woman came in who was nauseated, and her menstrual period was late, and you know, and she had been vomiting. She couldn't keep food down, so she really suspected she was pregnant, and she did not have a provider. And so, you know, we needed to do something about that at the time. So the student actually had to walk this young woman to a clinic a couple blocks away, and you know, because we were in Philadelphia, so that wasn't that big of a deal to do that. But the experience for the student of seeing all those barriers along the way for the this young woman was actually really remarkable. She came back and said, you know, she was upset about how the provider spoke to the woman, and so, you know, my goal is that then that student will never do that, and she'll learn to role model for people. So again, I encourage you all to get out there and engage with people. So this is how we can break down the walls, and that's why I kind of went through all of those things, is really take time to build relationships and trust. And the best way to do that is to be there and get in the community. And if you agree to do something, make sure you do it. In the United States, we tend to be kind of crazy about time. You know, if it's 4 o'clock, you're there at 4 o'clock. But many other places in the world, not so much. So oftentimes we'll have programs that's like from 1 to 4, and people come strolling in around 2:30, and the students will be looking at me going, well, nobody's here, can we go? And I'm like, we're here till 4. And so if you say you're going to be there, you have to be there. And even, you know, because that consistency is what makes people then continue to trust you and show up. Listen, I can't stress that enough. Make sure nurses and probably some of the other fields, we're problem solvers, so we listen to a problem, it's like, I got the answer, I'm going to take care of that. It's really bad practice. We need to take more time, especially in the community, take more time just to go, okay, so what do you think we should do? How do you think this would work? And a really good example of that is, again, I'm out in the Arab community a lot, and so we're out in this mosque after prayer, because that's when everybody's there, so we do a lot of programs there. And all the men after prayer come out and they're hanging out in a really interesting way, because men in the United States don't do that. The men really bond and they stay together, which I think is a fascinating thing. But they're smoking cigarettes. And I'm like, oh, this has got to stop. We got to stop this. So I go to the director, the head guy, and I said, I think we should do a health project for smoking cessation. He goes, I don't think you should. I go, no, I think that would be really good. These guys are all smoking every Friday. It's really awful. I said, you know, you'd have clean air out in your parking lot. It'd be really good for you. And so he finally just let me go. My students put together an amazing smoking cessation program, because I said, you know, we've got these men, you know, you're women, you know, think about this, and great program. 2 guys showed up. It wasn't their issue. They don't care. It's not an issue for them. So again, you really have to listen. That was like, okay, I'm an idiot. You know, I learn, and again, address the identified needs. So, and I do really encourage you with the population, if you have people, and Lancaster's not far.
No,
Yeah,
we're in Lancaster County.
Yeah, and it's a great name for Millersville. I mean, get your name. It's really great PR, but it develops you as a person. It really is valuable. So that's what I want to say to you, is learn about the groups in your community. I'm health, so learn about the health practices, but certainly cultural practices. It just makes you a better person. I know over Olympics you heard all about coining. They've been doing that well before the swimmer guy was doing it. You know, there's all kinds of things that people do. So thinking about that, we can make a difference locally with local groups, but we also need to think about that ecosystem of the policy groups, and thinking about how we can be much more upstream, which means directing the problem where it is occurring, not downstream of, oh my goodness, look at all these immigrants and refugees we have and unauthorized people. And that means we need to have a voice at policy. So we need to let our legislators know, when they're thinking about a war, what does that mean? What does that mean to that 84-year-old woman and her family? When they're thinking about economic decisions and trade agreements, what does that mean? It may be good for the United States, but is it good for other countries? And if it's not good for other countries, it's really not good for the United States. So we need to be better, much better global citizens. And thinking, all of those kind of impacts and having a voice. Now, I was thinking of nursing, but it certainly would be for all of you, of get out there and engage and share your experiences with people, because when people start mouthing off about Arab terrorists, I am right on that going, really, where is that coming from, and who do you know to say that? Again, engaging people in thinking of how did we get here and how can we prevent that? And then finding your voice. Write op-ed pieces, write editorials about, if you could get out there, engage in your experience. If you're asked to be on the radio, don't say no. Because sometimes if you get involved enough, you get asked. What you need to do, though, is work with somebody that you can get a quick soundbite, like something that's really catchy that they're going to pick up and keep playing. So just make sure you have, just work with somebody for that. And it's not that hard. Engage your legislators. They do want to hear from you. Pick up the phone. I say to my students all the time, because I do call my policymakers, but they have to be nice to you. Because you're a constituent and you're going to vote. So they're not going to be mean. And then you've really done something for the day. I mean, you can go back to bed. Because you just tell them about what it is that is important to you, and they are writing it down, and they do really want to hear from you. Because if they don't, they think you're okay with everything. And I also encourage you to engage enough to hold public office. I am not a person to run for public office because I don't have a filter. And so it would be troublesome. But perhaps other people do have filters and they could run for public office. So I don't know where we are with time. Ooh.
3 minutes.
Oh my gosh, I talked. I'm so sorry. All right, so any questions or comments? I am so sorry I talked so much. No, I wore you out. Yeah.
As an immigrant myself, I understand the pain of being torn apart from your family. But it's true, like what you said, it is very it hurts a lot. Just to be taken apart from them.
Oh, thank you. Thanks so much for sharing that. Yeah, it is a big challenge.
I just want to say too, one thing we can do, I worked in education for 10 years and I work in healthcare setting, is you need to confront your coworkers. When they say really unfortunate things, and this just happened last week. I work up in Harrisburg, and I was getting a report. She was shift change, and I said, and my one coworker was split in 2 hallways, and she had a patient in my hallway, and I said, well, let me tell you a little about him in case you're in the other hallway and he needs something. I don't like to go in blind. And she said, all you need to know is he's an illegal immigrant. He shouldn't even be here. And I went, excuse me, I don't care. And we had this altercation, and this gentleman lived in this country for 20 years. Yes, he's unauthorized. He's bilingual, and it's a sad situation because he's only 51 years old and he's in complete renal failure because he has undiagnosed high blood pressure that killed his kidneys. So he's in our hospital getting dialysis, and he's probably not going to necessarily go back to work. And he didn't go to the doctor because he didn't feel the symptoms until he was really sick. But I couldn't believe my coworker. I mean, I worked with her for over a year. I had no idea that she was like that attitude. And even when I was a teacher, I had students come to me like, I don't want to have that teacher. And I would have to go to the guidance counselor. I said, why not? And she said that he was talking about he hated illegal immigrants, my students would confide in me because they were afraid. And if they are fearful that their own teacher, in education, we don't report. It's not our job.
Right.
Our job is to educate everybody regardless of their status. But I had students who actually were fearful, and they would be asked to be switched out of classes because of sentiments that their teachers would say. And I was like, oh my gosh, I had no idea, because we don't necessarily talk to them. But that's where we can make the changes just in your everyday lives, when we hear stuff.
Yeah,
Everyone can tell us their opinion, but they don't know how it's going to impact.
Yeah, I've been working on that too, of confronting people. I mean, and saying, why do you feel that way? And on Facebook, I confront it right. I have no tolerance. Stop spreading hate is what I say.
We're silent. I definitely don't agree
Right.
upset people. But I was like, this is ridiculous because it creates a lot bigger problems. And,
Right.
nothing will change if we're in the silent majority.
Right,
I point
absolutely.
out a post, anytime on Facebook I see a post that is promoting violence against women, I say it right in the comments every time.
Yeah, yeah.
And
I think
I've had
we-
people like unfriend me. that I've been friends
we
with for
need it,
10
we
years.
do, we need
And I
to,
don't make a big deal. I'm just like, this post is promoting violence against women, and that's all I say.
right,
And I move on, and I've had people unfriend me because of it. And it's like, that's fine if you don't have an
Right.
issue with that, then we don't have to be friends.
right. But yeah, we need to start coming together because we are a nation of immigrants. That's who we are. All right, thank you.
Thank you. Nice job.
for coming.